Hello everyone, I am Dr. Bandhala Rajan, your Dermatology ADR faculty. Today we are here to discuss about the recent INICET July 2023 recall session. We will go the questions one by one. If you see the questions, there are multiple questions as in dermatology. Among that, almost 70% questions are direct repeat questions. So I hope you answered those well. We will go to the first question. Match the column A and column B. In the column A, they have given the diseases like erythrasma, pityriasis versicolor, tinea capitis, and vitiligo. In column B, they give color yellow, coral red, pink, green, and milky white. Basically, they have given disease and their Woodslam finding. They wanted you to connect. In these options, we know clearly that erythrasma has coral red fluorescence. That is very, very easy. So you can match easily. So we will see what are the options are having B in the first. So A and B are having first erythrasma has coral red. Next we will go to pityriasis versicolor. Pityriasis versicolor has a orangish yellow fluorescence or golden yellow fluorescence in Woodslam examination. So pityriasis versicolor, it is yellow color. This also easy. So 2 is A. So automatically you can rule out. So the answer will be A in this. That is the correct answer. We will go and see the next options and we will make sure our answer is correct. In this tinea capitis, which is characterized by blue-green fluorescence, vitiligo, we have already discussed in the sessions, vitiligo will accentuate in Woodslam examination. Means, if it is white color, there will be more white in Woodslam examination. It will be delineated from the surrounded area. So, vitiligo, it will be milky white. So, third will be option D. Fourth will be option E. So, the correct answer is option A. We have discussed multiple times regarding the Woodslam finding and various disorders, which is a very important question for INICET. Even for upcoming examination, it can be repeated. So we have to know some common disorders and their Woodslam finding. Erythrasma, it is very easy, which is coral red. Pseudomonas, we know, whenever Pseudomonas is there, it will be greenish discoloration, so green color. Cutibacterium acne, which is orange yellow color. Cutibacterium acne is implicated in the pathogenesis of acne. In fungal infections, pityriasis versicolor, it will be yellowish fluorescence. In tinea capitis, there are two infections. One is Pemphigus, another one is a Microsporum canis causing grey patch. Both will have fluorescence, both will have bluish green fluorescence. Apart from the infectious conditions, in the non-infectious conditions, you have to remember two. One is porphyria, which will present with the red fluorescence in urine and teeth. And another is vitiligo, which will accentuate with the milky white or bright white in color. These are the very important points we have to know. Next question, non-scarring alopecia is a feature of all except option A, androgenetic alopecia, option B, telogen effluvium, option C, frontal fibrosing alopecia, option D, alopecia areata. It is almost a repeat question, same question as in previous INICET. They are just asking what are the non-scarring alopecias except. So they are asking which of the following is the scarring alopecia. There is a double negative. So they are asking which is scarring alopecia. To answer this question, we have to know what are the scarring and what are the non-scarring. We can easily remember this. If you are remembering non-scarring, you can remember easily scarring. In the non-scarring alopecia, first you have to remember all the patterned baldness are non-scarring, like androgenetic alopecia and female pattern hair loss. Both effluvium are non-scarring, anagen, telogen, both. You have to know areata is the prototype of non-scarring alopecia. Whenever areata happens, if you treat it, the hair will grow back. So it is a common non-scarring alopecia disorder. Then mania is a non-scarring alopecia. You know, mania patients will have intermittent periods of normalcy. So you can remember in that way. Trichotillomania also, whenever the patient doesn't pull the hair will grow back. So it is a non-scarring alopecia. And colored tinea, capitis is a non-scarring alopecia. Why colored? So just to remember, there are two tinea capitis with color like gray patch, black dot, which are also known as ectotrix, endothrix. Those are non-scarring alopecia. Two S are non-scarring, SLE and syphilis, secondary syphilis, which is leading to mouth-eaten alopecia. If we are remembering this, we can see the scarring alopecias. First, scarring alopecia causes, if the name is fibrosis, something like a frontal fibrosing alopecia, which is a scarring, and the name meaning severe destruction of hair, something like folliculitis decalvans and dissecting cellulitis of scalp, means severe destruction of the hair follicle, so hair follicle won't grow back. Then in the inflammatory condition, we have to remember a condition known as lichen planopilaris, which is very important. In idiopathic, there is a condition known as pseudopelade of Brock. There we discussed colored tinea capitis. Now in scarring alopecia, it is single name tinea capitis. Means Kirion favors. They are having single name now, so you can remember in that way. Single name tinea capitis. In non-scarring, we discussed SLE. In scarring, discoid lupus erythematosus is a scarring alopecia. And final one is EC. Post-traumatic and burns will lead to destruction of the appendages if it involves the damage. So it will lead to scarring alopecia. Now we will come to the question again. Not scarring alopecia is a feature of all except androgenic alopecia, telogen effluvium, frontal fibrosing alopecia, alopecia areata. We discussed all patterned hair loss are non-scarring. So that is out. All effluvium are non-scarring. That is also out. Areata is a prototype of non-scarring. So that is also out in this question. So only scarring alopecia in the option is frontal fibrosing alopecia. The name itself has fibrosis. So that is the correct answer for this question, which is a direct repeat of previous NEET. This thing you have to remember because it can be repeated again also. Next question. A patient presented with itchy scaly lesion in a Christmas tree pattern. What is the diagnosis? They have given the image, I hope. Yes, many people told they gave the image and they asked something like a Christmas tree pattern here. And here one big patch with some collarette of scales. Whenever there is a scaly lesions in a Christmas tree pattern, it is more towards pityriasis rosea, which will have characteristic collarette of scales. Here in the image you can see, this is the collarette of image and the patch is known as herald patch, which is the mother patch. First patch to appear in pityriasis rosea. So for this question, the answer is collarette of scales in pityriasis rosea. Lichen planus with thicam striae, it is not. Psoriasis with Ornoff ring is also not the answer. In seborrheic dermatitis, which will mostly involve the scalp, so that is out. You see, psoriasis with Ornoff ring, there will be a plaque surrounded by a hypopigmented halo. This hypopigmented halo is known as Ornoff ring. Why this hypopigmented halo happens? It is due to reduced prostaglandin E2 synthesis. Whenever you treat psoriasis with topical steroids, phototherapy and all, it will lead to reduced prostaglandin E2 synthesis. Prostaglandin E2 is mainly implicated in the vasodilatation. So whenever it is reduced, it leads to vasoconstriction. So in turn, it leads to hypopigmented halo. Okay. So here, psoriasis with Ornoff ring option is also out because of that. Lichen planus with thicam striae. Lichen planus, we know it is more commonly involved the flexural area with 6 piece, pruritic, polygonal, purple colored papules and plaques. If you see the plaques, there will be fine white lacy reticular network, which is known as thicam striae. White lacy network you can make out. That is thicam striae, which is more prominent in the mucosa. In the mucosa, you can make out here. This is the thicam striae. One point you have to know, thicam striae represents hypergranulosis. Whenever granular layer is thickened, it leads to thicam striae. In lichen planus, okay. So thicam striae is also out. So the answer is collarette of scales in pityriasis rosea. So the clue here is Christmas tree pattern, which is characteristic of Pityriasis rosea, and in the mother patch there will be collarata scales. Next question, a patient presented with linear deposits of IgG and C3 on direct immunofluorescence. What is the diagnosis? They have given the DIF image. There is a linear deposits of IgG and C3. In the image you can make out. The options given are Pemphigus vulgaris, Dermatitis herpetiformis, Pemphigus foliaceus, and bullous pemphigoid. We have discussed already immunoblast disorders are one of the favorite topic for INICET. In the same way, two questions have been asked in immunoblast disorder. We will come to this question first. Here they have given the DIF image and they have given the options. So if you see, first we have to find where is the deposits. There can be two types of deposits. One is like in the intraepidermal, another is in the DEJ junction. Whenever there is a linear deposits, it is more towards deposits in the DEJ junction. Because whenever it's intraepidermal, it will be fishnet pattern. So that is out. So the first clue is it is in the DEJ, means it is a subepidermal disorder, subepidermal blister. And they have given IgG and C3 on direct immunofluorescence. So it is more towards bullous pemphigoid. That is the answer. Now we will see other options, how they look like. In the first image, you can see the fishnet pattern. Whenever you see fishnet pattern in immunofluorescence, it is towards intraepidermal blisters because it will stain between the keratinocytes. Keratinocytes will be like this, na? So the stain will be between the keratinocytes. So it will lead to that fishnet pattern. Intraepidermal. Whenever intraepidermal pattern is there, you have to see if the fishnet pattern presents in all layers or top layers. Top layers. If it is in all layers, it is towards Pemphigus vulgaris. If it is only in the top layers, it is Pemphigus foliaceus, which I have discussed already. Just I'm recapping. Next, if you are seeing linear deposits in DEJ, something like this, which we have asked in our exam. You have to see what is the type of deposits, whether it is IgG or IgA. If it is IgG, it is towards bullous pemphigoid. If it is IgA, it is towards linear IgA disease. Next, there can be some other deposits seen in the dermal papilla, something like this. Deposits in dermal papilla. Which is more of IgA. It is seen in dermatitis herpetiformis. Now you see, you can answer this question well because the deposits in the dermoepidermal junction and it is made up of IgG and C3, it is bullous pemphigoid. If they are given IgA, it is towards linear IgA disease. So the answer here is bullous pemphigoid. Next, they have asked a question which is an assertion and reason based question. Like in assertion, they have mentioned a 60-year-old presented with a flaccid pulla and suprabasal acantholysis in histopathology. The reason they have mentioned row of tombstone appearances seen in Pemphigus vulgaris. The options here are both assertion and reason are true. Reason is correct explanation for assertion. Option B is both assertion and reason are true, but reason is not correct explanation for assertion. Option C is assertion is true, reason is false. Assertion is false, reason is true. Both assertion and reason are false. If you see this question, first we will see whether both the statements are true or not. Then we will see about the whether it is a correct explanation or not. First you will see assertion. Flaccid bulla on suprabasal acantholysis. Yes, whenever you see flaccid bulla, it is more towards Pemphigus group of disorder. Pemphigus, more towards Pemphigus vulgaris. So which will have suprabasal acantholysis, which is correct statement. Yes, assertion is correct. Then row of tombstone appearance is seen in Pemphigus vulgaris. Row of tombstone appearance seen in Pemphigus vulgaris, which we know. Whenever there is a suprabasal acantholysis, there will be row of tombstone. The basal layer only attached to the dermoepidermal junction, which is also a true statement. Now we will see the reason is correct or not for the assertion. You tell flaccid bulla and suprabasal acantholysis in Pemphigus, which is due to antibodies against desmoglein 3. That is the correct reason for the flaccid bulla and suprabasal acantholysis. Na? It is the reason this is developing. It is the reason that suprabasal acantholysis and flaccid bulla are developing. Row of tombstone is just one of the component of Pemphigus vulgaris, which is not the reason or correct explanation for the assertion. Right? So in this question, the answer is both assertion and reason are true, but the reason is not the correct explanation for assertion. Because the correct explanation should be antibody against desmoglein 3 is the reason for this condition. So that will be the correct reason. Here they just mentioned the another component of the disease, which is not the correct explanation for the assertion. Right? I hope you understood. Here are some images of Pemphigus vulgaris. There are flaccid bullae. Oral erosions. Whenever you do, there will be intraepidermal cleft or blister. With suprabasal acantholysis. Intraepidermal cleft at suprabasal level with row of tombstone. This is row of tombstone. Only single layer of cells are there, na? This row of tombstone appearance. Next question. Autoantibody in systemic sclerosis is. I don't know how they asked this question. Like they gave the clinical features of systemic sclerosis and they asked that antibody or not. But I hear the question was related to the antibody in the systemic sclerosis. The options are anti-centromere antibody, anti-U1RNP antibody, anti-Rho antibody, anti-LA antibody. For this, we should know the common antibodies and the diseases related to it. These are the common antibodies which can be potentially asked in ANA, which is seen in all CTDs. Anti-dsDNA and anti-Smith are seen in SLE. Smith and dsDNA are more related to SLE. Anti-histone antibody is related to drug-induced LE. Right? Anti-Rho and anti-LA are related to Sjogren syndrome and subacute cutaneous LE. Anti-centromere antibody and anti-topoisomerase antibody are related to systemic sclerosis. Among them, if you see anti-centromere antibody is related to localized form. So you can remember like CL, casual leave. You can remember like casual leave, CL. Okay. Anti-topoisomerase antibody is related to diffuse type. Right? You see anti-U1RNP, which is related to mixed connective tissue disorder, MCTD. And antibodies like MI2, MDF5, NXP2, TAF1 gamma, JO1, those are related to dermatomyositis. These are the common autoantibodies we have to know. Now we will come to the question again. Like autoantibody in systemic sclerosis is anti-centromere antibody. That is the correct answer we have discussed now, na? Which is related to localized systemic sclerosis. Localized cutaneous systemic sclerosis. Anti-U1 RNP is related to MCDD. Anti-ROD are related to Jogren and SCLE. So those are wrong answers. Right? So this is very important. This antibodies and autoimmune diseases. Next, they have given some image and they have asked identify the lines. Like option A, Blasco lines, option B, Langer lines, option C, dermatomal lines, option D, resting tension lines. I'm not sure which image is given. There are 3 types of images, whichever can be given. If they are given image like this, like in the image, if you see, the lines are not straight or parallel. They are in a curvilinear or curved pattern, S-shaped pattern. Here you can make out a S-shaped pattern. The scalp it is oval-like. Here it is almost like a fountain-like pattern. If they are given image like this, it is towards Blasco lines. That is for sure. If they are given S-shaped or oval-shaped or fountain-like presentation, it is Blasco lines. We will see about other lines, so it will be easy for you, like what kind of question asked in the exam. This is the Blasco lines we have discussed. This S-shaped, oval-shaped or fountain-shaped. You know, Blasco lines are basically imaginary lines of migration of the epidermal and melanocytes. Embryonic migration lines. So cells like keratinocyte, melanocyte. And another thing you can remember is the diseases which are related to Blasco or something like verrucous epidermal nevus. Which will present in the Blasco, line of Blasco. Next, if they are given some image like this, the parallel lines in the limbs, they are in a vertical pattern, straight lines. They are straight. They are Langer lines. Langer lines are basically how the collagens are deposited in the dermis. So there will be the arrangement of collagen is like that. So there will be more better healing if you are doing a surgery or surgical incision parallel to the Langer lines. So if they are giving straight lines like this, it is Langer lines. If they are given some image like this is basically dermatome. Everybody knows, na? This is dermatomal lines. Dermatome is basically an area of skin supplied by a single nerve root. If they have given option like resting skin tension lines, which is almost similar to Langer lines, they are for planning surgeries with a better cosmetic outcome. If they are doing parallel to the RSTL or Langer lines, they will have a better cosmetic outcome. Almost similar. Next, they have asked something related to clue cells. I am not having the exact question. I think they asked what are basically clue cells. The 2 options available are epithelial cells with bacteria at the border, macrophages engulfed dodal and bacilli. Dodal and bacilli is basically lactobacillus. No need to confuse with that. Other name for lactobacillus is Dodelin bacilli. So first we have to know what is clue cells and where it is present. Clue cells are basically, we have already discussed in STD. Clue cells are a clue to bacterial vaginosis. Seen in bacterial vaginosis, and it is one of the criteria in the Amsel criteria. Bacterial vaginosis is basically if you see the pubertal or post-pubertal adult woman, the vagina is colonized by lactobacillus, which will maintain the acidic environment. Whenever there is a replacement of normal bacterial flora by anaerobes or other mycoplasma organisms, which will lead to increase in pH and vaginal discharge. That is the bacterial vaginosis. It is not an infection, which is the replacement of normal bacterial flora, which is lactobacillus, we know. So, macrophage engulfed lactobacillus is obviously a wrong answer. So, first we will see the image of clue cells. This is a vaginal keratinocyte, which is the borders are fuzzy due to attachment of organisms. The borders are not clear, na? Vaginal epithelial cells borders are fuzzy, or borders are not clear because the bacteria attach to the borders. So it is not clear. So it is clue cells. So if they are asking clue cells are basically vaginal epithelial cells which bacteria at the border, which makes the border indistinct. So that is the correct answer for this question. Okay. I'm not sure about other options. They may have given something like trichomonas. They may have given something like school of fish appearance in Shankroid. I'm not sure what the options are given. Those are the potential other options can be given. Like they can given trichomonas as an option. Flagellate organism. Option D may be school of fish. Just to confuse. So the answer for clue cell is, which is an epithelial cell, vaginal epithelial cell with bacteria attached to the border. Right? Yes, thank you. I hope the session was useful for you. And I hope many of the questions are from the previous INICET. So especially in dermatology, I hope you would have done well. All the best for the results. Thank you.